Hello, everybody. My name is Lowell Kabnick. I'm the moderator of Vein and Lymphatic University Grand Rounds, and we'll start promptly. Professor Ochoa is going to give us a talk on the SAVVE trial, insights into the VenoValve, and then we'll be followed by two professors, Professor Goel, as well as Professor Ochoa. So the floor is yours.
Thank you. Thank you, Dr. Kabnick, for the introduction. My talk will be talking about the VenoValve and the SAVVE trial and share what insights we have from that ongoing trial. These are my disclosures. Deep venous reflux treatment has been really by compression therapy, various forms of compression therapy to various grades and degrees. And in addition to that, for patients with venous leg ulcers, who a significant proportion of patients have deep venous reflux, we do wound care, various forms of wound care. But really for those patients with leg ulcers, after we treat the superficial venous reflux and potentially venous outflow obstruction, we have not had any surgical option to treat deep venous reflux or correct it. There has been a lot of publications on deep venous valvular reconstructive surgery, and that has been very nicely summarized in a recent systematic review by Dr. Maletti and al. From Italy. However, there's been a lot of different techniques and a lot of different strategies and the dissemination of that surgery has been very limited to only a few centers worldwide. One novel treatment is to have the bioprosthetic valve that does the job of the deep valves and replace them. And the VenoValve is a valve that's been designed for that. It has a metal frame and in porcine aortic valve that's sutured to it. And this has been tried in a smaller group of patients, and that study was led by Dr. Ochoa and published with very good results. So the SAVVE trial is the United States multi-center trial looking at the VenoValve. And in that trial, patients who had deep venous reflux of at least a second and advanced venous disease, CEAP C4b, 5, or 6, were enrolled in that trial. All those patients, the majority of patients had C6 disease, and all those patients were ruled out for lymphedema. If they had superficial venous reflux or iliac vein obstruction, had those treated and taken care of prior to enrolling in the study, and they had persistent symptoms and deep venous reflux. When we look at patients with ulcers in that study, 75% of those patients who had ulcers, which are the majority, approximately 60% of the patients in the trial, had an ulcer for more than a year. So those are the patients that come to your clinic, who have ulceration, you try different forms of compression, you try to rule out any other concomitant pathologies, and they just come back. And really, there's no option for them to treat the deep venous reflux. So we enrolled 75 patients in that study, and this is the most recent data that we have for 2 years follow-up. And you can see that the VCSS score, the Venous Clinical Severity Score, significantly decreased in all the patients in the group, from 16 to 8.9 after 2 years. And if you look at the clinically meaningful improvement, which is defined in the study as a VCSS decrease of at least 3 points, you see that this group of patients even had more improvement than the overall population, and there's a significant proportion of patients who had clinically meaningful improvement. Looking at the percentage of patients in that trial who had clinically meaningful improvement or a VCSS score decrease of 3 points or more, you can see that 84 or more than 80% basically of the patients at 1 year and 2 years had that outcome, that improvement in outcome, which is really remarkable for this challenging patient population. Pain score dropped by at least 50% also. That is sustained, and the pain drop started early on at 3 months, but was sustained up to 2 years, as you see in this graph. And parallel to that, the patient's quality of life, as was measured by the VEINS-SIM and the VEINS-QOL tools, significantly improved. and this is the veins SIM tool, and this is the veins QOL tool, and both had improvement around the same time that the pain score improved, around 3 months, and that improvement was sustained up to 2 years so far. Now, when we look at the venous ulcers in that trial, venous ulceration was looked at as presence or absence and complete healing, but there was also assessment of the surface area of those ulcers. And there's an application, the SWIFT app, that measures based on images and a calibration tool, the size of the ulcers, and the surface area reduction was also measured and traced. So if you look at ulcer healing in general, you can see that approximately, and this is only looking at 1 year, because the analysis for the surface of ulcers have not been done for the 2 years, but it's in the works. You can see that 50% of the ulcers completely healed and 91% improved or healed at 1 year after placement of the VenoValve. And if you look at the surface area of ulceration, that significantly decreased from 17.4 centimeters square at the beginning. There was to 2.1 centimeters square total at 1 year. And this is a similar curve, but showing the percent reduction of ulcer area. You can see that there's an early drop even within a month after the surgery, and that continues all the way to 1 year, from like an 88% reduction basically in the surface area of the ulcers. Now, this analysis was stratified by the time of ulceration, the duration of ulceration, and you can see that the patients who had ulcers of duration of 1 month or less than 3 months, those almost completely healed, with very good in a very fast period of time. But you could see that on the other hand, patients who had ulcers for more than 1 year, their trajectory was a little bit more retracted, and it took a longer time to heal those ulcers. But still, overall at the 1 year mark compared to the time of surgery, you had an 85% reduction in the surface area of ulceration, which is a great improvement for this patient population. The improvement in VCSS score, this is looking at only patients with ulcer, is very similar to the overall patients. And the improvement in the VCSS also at 1 year was similar to the overall population. Another analysis that we looked at and into the SAVVE trial, we looked at patients who had history of DVT versus patients who did not have history of DVT prior to treatment. So the thrombotic patients, which constituted 80% of the patient population, 20% of the patients did not have any history of prior DVTs. And we can discuss that with Dr. Ulloa. We have already had some discussions that, maybe all of them have thrombotic events, but maybe we don't know, or clinically they were not brought to the attention of the physician at the time. Regardless, the characteristics of the patients were very similar baseline, as well as the characteristics of their reflux pattern and VCSS score were very comparable. I don't have that slide here for the sake of time. And if you look at those two patient populations, you can see that the improvement in VCSS was significant in both. In green, you can see the patients who had primary reflux, and the patients who have not thrombotic reflux is in orange, and both had a significant decrease at 1 year in their VCSS score, 8.7 drop in the primary versus 6.2 in the patients who had post-thrombotic syndrome. And similarly, the patients who had the clinically meaningful improvement, which is 85% of the group in that analysis, both had also significant drops in their VCSS scores, 7.5 and even 9.3 in the patients who had primary insufficiency. So in conclusion, the VenoValve is an effective treatment for patients with deep venous reflux and ulcers, and despite conventional medical and surgical therapies. Ulcers, especially the ulcers of more than 1 year duration, this group of patients healed more slowly, but they did have more than 80% reduction in the area of ulceration after 1 year. and they benefited from the surgery. And the overall improvement in measures and quality of life for advanced venous reflux and deep venous reflux really opens an opportunity for those patients and who have really no other options to have some surgery that can improve their patients' outcome and also an option that lasts, that's durable at least for 2 years so far, as long as the trial has been collected. And we're starting to collect data for the 3-year outcome. The device is getting reviewed by the FDA, and hopefully will get approved in the near future. Thank you very much, and happy to take any questions.
Thank you very much, CEAP Chaar. That was unbelievably exciting. Obviously, there are going to be lots of questions. We do have one already, and that's patency of the valve in your trial. And that was suggested by Dr. Iyad Bashara from Egypt.
Yeah, so the incidence of thrombosis and DVTs was approximately 10 to 12% in the trial. Few patients got thrombectomy, mechanical thrombectomy, and the patency of the vein and the valves was reestablished. And some even patients who had DVTs in the area and did not get thrombosis, a lot of the DVTs resolved with time. And based on, I would say, equivocal ultrasound results, because of the metal frame, you cannot really see inside the valve. You cannot assess whether the valve has reflux or not. And that has been one of the major challenges of that trial. But based on the patency of the vein below and the respiratory phasicity, so basically showing that there's respiratory variation in the vein where the valve is implanted, it's 90%, 98% actually.
Okay. Thank you very much. I'm going to move right on to Professor Gol, who's going to comment or ask questions. And you have 5 minutes, and then we'll go to Professor Ochoa.
Thank you very much. I really enjoyed that presentation. I've been following this space for 20 years, and this is the furthest we have come in a clinically effective prosthetic valve implant. So congratulations to all the developers and all the implanters. I have many questions. I think the real key to this work is around case selection. So I think what I'd like to do is just to maybe just push you on a couple of things. First of all is around, does the valve actually do what we want it to do, which is to restore patency and restore flow in the correct direction? And B, what were the dynamics of case selection? Because we have many patients who may have some deep reflux. There's a big difference between 1 second of reflux in a segmental part of the deep vein versus a torrential 10-second reflux throughout the deep system. And there's obviously patients with poor mobility, calf muscle pump failure, all these other factors. So 2 questions really for you. One is around, can you tell us about the competence and the patency, or the competence of the valves, but also how was the cases selected in this trial, please?
Thank you very much. These are all great questions. So first of all, I mean, the valve is not intended to restore patency of the vein. The veins are patent. So one of the selection criteria was that the patients had venogram prior to the implantation, and the venogram showed that the vein in the upper third of femoral vein, upper third of the thigh, was patent and could accept a 9 millimeter or a 10 millimeter valve, which is the sizes that were used. So it's not about patency, it's more about reflux and stopping that reflux. And I would say that most patients enrolled in the trial, I don't have the exact number of what was the mean reflux time, but I can tell you from the patient that I've treated in our center, which were 7, which was the highest number, most of those had 4, 5 seconds or more reflux. So these are patients, and those are patients who had femoral and popliteal most of the time reflux. So these are patients with wide veins that are refluxing in the reverse direction. with the patient selection, I think this is something that we're trying, the selection criteria were placed. So the only criterion from an anatomical standpoint was that the vein was patent and there was reflux at least a second. These were the only anatomical criteria in the absence of, venous outflow obstruction or superficial venous reflux. But as we understand the disease process more, there are a lot of anatomic variation that can potentially impact how the valve works and maybe act as leak channel around the femoral vein. And one of the things that we're actually looking at, and an abstract that will be submitted soon, is the anatomy of the femoral vein. A fair number of patients have a bifid kind of femoral vein trunk that join into the popliteal vein. And you can imagine if you place a valve in one of them and the other one is widely refluxing, that will be, that may not, control the symptoms as much as patients that are, that have only one channel. So this is what I have, my answer to your current questions.
Yeah. And that's very helpful. Look, I think this is a really exciting time. I am delighted and eager to see the longer term outcomes. I think there'll be a lot of work to build on this, to look at case selection, to look at the optimum place to place the valve, to look at the best groups of patients to take advantage. And I was also very pleased that you said that treating the superficial reflux and the venous outflow first is very important. These are very established treatments that we know work well. And I think initially, especially, it's very important that this is not seen as when it does get approved, hopefully soon, does not seen as a gateway to suddenly start treating everyone with deep reflux. But no, thank you very much for your presentation.
Thank you very much, Professor Goel. I have a few questions that have been sent to me. Was there any patient that was not successful and that you could not place the valve?
Yes, there were
one question, and then the second question is post therapy anticoagulation.
So there were 2 patients in the trial, 2 out of 75, where the valve could not be implanted, and that was technical, maybe planning. And one of the things that I did, at least for the patient that I treated, that I was not aware that was not done universally, is I did an intravascular ultrasound and mapping of all the patients that I implanted. And I basically kind of mapped exactly where is the diameter that's best fits the valve that I want to place. And correlated with angiography. So when in the OR, we kind of knew where we were going. And I guess those 2 patients, I was not involved in the cases, but it sounds like the post-thrombotic changes in the vein were too bad to be able to put the valve. Having said that, in a couple of the cases that I performed, the vein was, the valve was very snug, so we had to do a patch angioplasty with a bovine pericardium in order to have the valve sit, comfortably without, tearing the vein, and that happened in 16% of the cases out of all the patients. So a fair number of patients needed, some augmentation of the vein, but we were very careful because the key is to have it snug, because if you have some leak around it, that's a big problem. That defeats the purpose of the valve. So these were the 2 cases. And I'm sorry, what was your other question? I kind of
Post-operative anticoagulation.
So anticoagulation. So the protocol was to start Lovenox within a few hours of the implant, and we were pretty aggressive in anticoagulating those patients. And in the overall trial, there were approximately 10% incidence of hematomas after the surgery. And that's probably because of the aggressive anticoagulation. But most of those hematomas resolved. And the patient stayed on anticoagulation for Lovenox for the first 3 months. and then were switched to DOAC for at least a year. And I would say most of the patients in the trial continue because a lot of those have a bad post-thrombotic syndrome and history of DVT, so they are anyway on anticoagulation. And at least the patient that I treated, I tried to keep them on anticoagulation for the longest because we don't know really what the thrombogenicity of that valve is. Now, based on Dr. Ulowa's pilot trial, I think there was only one thrombosis, which is kind of reassuring. I mean, their follow-up is 3, I think 4 years by now, but I think they published it 3 years. So
Thank you very much. I'm going to switch to Professor Ochoa, who actually was a pioneer with this valve in Colombia, so has a fair amount of experience, and it'd be interesting to have his comments and particular questions. And then the last question I'm going to ask after that maybe would be the future of endovenous implantation as opposed to open. So the floor is yours, Yoa.
Thank you, Professor Kapnick. I enjoyed the presentation, Cassius. That was fantastic. A very comprehensive review of this whole process that has been published. The last publication we have is about a couple months ago in Annals of Vascular with the whole 3 years experience. I invite you guys to check it out. It's pretty nice to see how we wrap it up, all this info. This is 60 years of errors, trials, errors, and we're just stepping on the shoulders of the people that has been brave enough to do those attempts in the past. And it's the first time that we have encouraging results that are opening the option of many things. Most of them were already being addressed here. The amount of reflux and the duration of reflux, which is the one that is important. We still don't know. We still are struggling to know which is the one that we're going to follow the lead in order to make an implant, or maybe 2. We're still figuring out how many valves the patient is going to need. The duplicity of the deep veins is something that also calls our attention, because that is on direct direction on who is having how many symptoms, depending on how many veins are saving the deep system or not. And the future, which is the last thing that Lowell asks me to go into the north of this direction, is going to be endo, of course. Stainless steel is something that we needed to try, is the opening step of something that should be nitinol in the near future, and has been already been some attempts that will see the light in the next 2 to 3 years with endo devices, which is something that definitely are going to stay for good. What is the thing that calls my attention the most and really bothers me a little bit is how we are going to anchor those endo valves in which system, because doing it open, it's really easy to put a couple of stitches that give you peace of mind, not only for a possible embolization for the patient, but for the sake of your coronaries as vascular surgeon. But in the endo is going to be a challenge. So we're so far relying on oversize of it. There is a long way to go, but we will see very encouraging results in the next 5 years or so.
Well, thank you very much, Jorge. And any comments, Professor Chaar, Professor Goel?
I think the endo it definitely is going to be very interesting. And I think from dealing with iliac stents and other one of the key to understand how to size those is really understanding hydration. Some of the research that I've done, supported by the AVF, the American Venous Forum, a small grant, is we've been trying to study hydration and its impact on iliac vein compression and vein sizing. And I think that's going to be important also in this space, because as patients when they come in for surgery, they're NPO. So we're kind of systematically dehydrating our patients when they're coming for procedures. And now we want to do venous procedures on them, but all the veins are smaller. So that is, I think, an important thing that we'll have to look at as we develop this and as we better understand the disease process and its treatments.
Manj?
Yeah, I want to echo what's just been said. I think endo is clearly the future, but we mustn't run before we can walk. We have to understand which patients are going to benefit the most. Once the endo devices are available, the cats will be out of the bag. And again, I can imagine my coronaries being in that situation where these little devices are in all sorts of funny places. And so I think what this should really spark now that we have feasible options for deep venous reflux treatment, we should really spark that almost basic scientific endeavor to understand which patients should we treat. I suspect it's a relative minority, even though 30, 40, 50% of patients with CVI do have deep reflux. I think it'll be a small minority that benefit from this, but they are desperate patients, so we have to do something for them, but we mustn't run before we can walk.
So I'm going to talk a little bit or raise the query of reflux and understanding the pathophysiology. And there's no answer here. And yet we look at reflux, but we're not sure that that really is the ultimate. That's what we're looking at now. It's an objective measurement. And I didn't hear about reflux correction. Maybe I missed it while I was doing something else. But very quickly, Siak, was there any reflux measurements post-valve, and were they stable?
Yes, so post-valve, I mean, this is one of the challenges of that trial is getting a good, consistent, and reliable measurement of the reflux. The paper is going to be out soon, but the reflux time did not change as expected. The changes in the reflux time were less than expected. In Jorge's pilot study, they achieved that drop in reflux time. In the SAVVE trial, we did not get that, and the reflux time was also even like 15, 20 patients after enrollment of 15 to 20 patients. The company changed the way they're measuring them, not changed, but tried to standardize it more, and they were sending actually ultrasound techs to all the visits, and still that has not really meet the mark.
So I think you're just emphasizing what I just said about reflux and trying to understand the pathophysiology of what's going on in multiple modalities. I'm going to thank everyone here, and I wanted to state that next week we're going to be talking about thermal complications and how to avoid. Dr. Esponda will be the speaker. Demetrius Kanathanasis will be a discussant, as well as Professor Evgeny Shadikov. With that being said, here is the flyer, and we look forward to seeing you next week. And thank you again for this informative talk.
Thank you very much. Thank you for
Thank you,
the
Lou. Thank you very much.